How's everybody doing today? Hope you had a great weekend and that this week's going good for you. My name's Bill Schroeder. A lot of you probably know that. Well, it's Tuesday. Got a technical tip for you. Let's talk about duplex evaluation following an endovascular aneurysm repair. What do you say? Hope you enjoy. So if you work in a vascular laboratory, this is not an uncommon examination. This is because people undergoing endovascular repair of an abdominal aortic aneurysm generally require follow-up for life due to the possibility of developing an endoleak, that is, active blood flow outside the graft in the residual aneurysm sac. So if you're doing this examination, you should be familiar with the classification of endoleaks. There are 5 of them. Do you know them? So here they are, endoleak types. Type 1 is a leak from the attachment site, and this is broken down into 1A from the proximal attachment site, or 1B, the distal attachment site. Type 2 is a patent branch with retrograde flow into the aneurysm, typically either a lumbar or the inferior mesenteric artery. Type 3 is a defect in the graft material. Type 4 is graft porosity. This is flow through the wall of the material. And type 5 is what's called endotension. This is an enlarging aneurysm sac with no detectable leak. So if you get a nice image like this one, pretty easy. We can see actually flow within both limbs of the graft. We're down below the bifurcation, so we can see both limbs, and we can easily appreciate flow outside that graft material in the residual aneurysm sac. Now this would require a little further study to determine where that leak comes from, but a clear endoleak. So here's another patient. We've measured the residual aneurysm sac about 6.5 centimeters. That's pretty large. Over time, that aneurysm sac will tend to decrease. We do see one little flash of color in this still image. Now, certainly we can't diagnose an endoleak from that, but raises suspicion. Also, note the hypoechoic appearance of that residual sac. Kind of suspicious. So here's a spectral analysis from both the left and the right limb of the graft. Normal multiphasic waveform, so obviously this graft is widely patent, delivering normal blood flow pattern to both legs. So here we're looking at a longitudinal image of the aorta. We can see the graft in the middle, a little bit of artifact. This is not atypical in abdominal applications. We can see a little flash of color, but nothing too convincing with regards to an endoleak. So I get rid of the color. Helps me a bit with the artifact. Not the greatest of pictures, but we can see the residual aneurysm sac with the graft in the middle. Note that hypoechoic area towards the left of that residual aneurysm sac, just above the graft. Also note the thrombus that appears to be moving with the pulsations. This is actually a type 1 endoleak. This was confirmed with re-intervention, and the graft was actually restented once again at the proximal attachment point. So when you're evaluating that patient post-endovascular aneurysm repair, looking for endoleaks, certainly you want to see if you can detect flow in that sac. But one of the most important things is to assess the size and echogenicity of that residual aneurysm sac. Remember, it should get smaller over time. Additionally, it should become more hyperechoic. When you see one that's dilated or not decreasing in size, and it has that hypoechoic echogenicity, suspicious for thrombus and or blood flow, think endoleak. Hope you enjoyed. We'll talk to you next week.